Ladies and gentlemen, all protocols observed. Good morning. Jameni, tumetoka chai, kwa hivyo tuko na energy. Good morning. Yes, that is more like it. As you've heard, I'm Caroline Juguna. I'm the country director for Path Kenya. And indeed, it's a pleasure for me to be part of this very timely and important summit. I'm honored to chair the next session, where we'll be zooming in on integrated data and information management systems, and also we'll get a chance to learn from the counties that have walked through that journey. And I want to invite you to this thought-provoking and very informative session that will delve in and discuss health management information systems, integration, digitization, and digitalization. I'm hoping by the end of this session we'll be able to distinguish what's the difference between digitization and digitalization. Now, when I reflect on the discussions and the presentations over the last 2 days, multiple speakers have referenced data, they've referenced information systems, and the critical role that strong HMIS systems have on enhancing health service delivery for improved health outcomes, as well as giving clients a better service delivery. Now, use of digital technologies and other modern information management approaches have had profound impact on HIV response. And I think we need to acknowledge, even as we talk of integration and expansion of HIV systems, information systems, we are riding on some of the investments in the HIV space. I think it's a HIV space where most of the automation and digitization was done, and now we are able to talk of facilitoid systems. And looking at the Kenyan context, as a country, we're in an exciting stage. There are some significant gains. We have the legal framework, we have the policies in place right now with the passage of the Digital Health Act, and now we even have the formation of the Digital Health Agency, which we'll learn more about it, that is leading us in the exciting journey of the digital health superhighway. So for this session, we've lined up a couple of presentations, both from the national level all the way to the county level where service delivery happens, as we look at the various aspects of health information management systems with speakers with practical experience. Now, our first presentation, we look at integrated health information management systems and surveillance. All right, I'm told we'll start with a virtual presenter. So we'll start with looking at digitization and the journey ahead. Kenya has entered into a critical stage in digitalization within the health sector, and it's really an exciting phase. As I mentioned, we passed the Digital Health Act. Now we have the Digital Health Agency that has been formed, and I know we do have some of the board members in this audience. And with us this morning to lead that discussion on that journey, we have Dr. Joyce Wameshwe from the Digital Health Agency, and she will be giving us, the thinking and where we are going with the digital health superhighway, as well as the journey for the country on digitization. So please join me to warmly welcome Dr. Wameshwe to make the presentation, and she'll be joining us virtually. Over to you, Dr. Wameshwe. I hope you can hear us.
Yes, good morning. Can you hear me?
Yes, we can hear you. Please proceed.
Okay, thank you. I'm unable to put my video. There's something I'm being told about it, but I think, let me just upload my presentation. Thank you. Please confirm that you can see the presentation.
Daktari, we can see your presentation. Please carry on.
Okay, so thank you, Caroline, and thank you to the organizers of this meeting. I'm sorry that I couldn't join you physically, but perhaps it's an opportunity to showcase that things can still go on digitally. So I'll be making a presentation on behalf of the Digital Health Technical Working Group on harnessing digital technology to optimize healthcare, which is in keeping with the topic that I was asked to speak on, digitalization and the journey ahead. Caroline, I like the fact that you did indicate that the Digital Health Agency is up and running, And we are happy to have from the county, from the COG perspective, 3 representatives. And I know in that meeting, we do have Dr. Greg Ganda, the CEC Kisumu, and George Karoki, the CEC Kirinyaga, who are part of the board members. So maybe you can clap for that. So I'm trying to move these slides. So the rationale for digital transformation in the health sector is based on what we are doing. What we are doing as a country regarding universal health coverage. I'm trying to remove these things so that you don't see them. Disappears. Anyway, so the rationale is that we are moving from curative to preventive and promotive health, and it's really based on a foundation of strong leadership and governance. And we have 4 pillars: human resources for health, health products and technologies, and of course we know all these things that we're talking about need to be financed. The story of health is free is really a story. Somebody needs to finance that healthcare. And then we have health information. And we like to pride ourselves that the health information pillar is the one that's going to make sure that all these other pillars run efficiently and effectively, and is going to provide information to the leaders, to the policy makers, to the people in leadership and governance, be able to make decisions on a timely manner. So the benefits of digital health, this is what we are envisioning we will have in the near future, starting in the next couple of months, is availability of real-time or near real-time data for decision making. We want Wanjiko also to be able to access her health data. This is one of the things that is in keeping with what the Data Protection Act provides, that your data, your personal data, you are the supremo in terms of the data subject is the owner of their data. And then harness the power of individual level health data. This has really been appreciated in the HIV program setting, and I'll be demonstrating a few things. But now we want to move from the HIV program setting and really expound throughout the whole health sector setting. So we want to be able to look at surveillance from an individual level point of view. We want to be able to look at non-communicable diseases and even, diseases, even things like epilepsy in children. We want to be able to see it more beyond the aggregate level. And then, of course, increase efficiencies. Efficiencies, we like to keep talking about costs, efficiencies in pre-authorization when it comes to health insurance, efficiencies in paying of those claims, but even efficiencies in simple things like triaging at the health facility. So in terms of the requisites for optimization of technology and innovation, there are certain things that need to be in place, and this is from the WHO digital health documents that are there. So one of the things is a strong legal framework. The second thing is we need to have meaningful collaboration and advanced knowledge sharing, which we are doing even in this particular summit. We need a visioning. We need a national strategy for digital health and innovation. So we visioned, we have a 4-pager now, I think it's about 10 pages, but this is one of the things that we are working on in terms of having a national digital health strategy. We have had some in the past. I think the last one it ended in 2018, but now we are very clear about where we are going in the next couple of years, and we want to have a costed strategy. Of course, strengthen governance for digital health, governance in terms of infrastructure, software, even the health data that is collected within the systems, and then promote people-centered digital health solutions. The user must always be at the center of these conversations. So in terms of legal framework, we like to say, people really talk about the Digital Health Act as the IT in terms of e-health, but we like to go back a bit and appreciate that already by 2017, the Health Act had pronounced itself that e-health is recognized as a mode of health service, that MOH shall facilitate, establish and maintain an integrated health information system. And the CS in charge of health issues is mandated in this Health Act to come up with e-legislation that covers on certain things, one of them being privacy of personal data, health data. So we are happy that Data Protection Act came in and did exactly that. And the Data Protection Act really talks about processing of personal data. That's where their mandate is. As long as the data can identify you, like what we are seeing on social media, the Office of the Data Protection Commissioner saying telephone numbers is part of personal data. So people ask, so why did we need a digital health data? Digital Health Act legislation? Is because we went ahead and took what is in the DPA and put it in terms of the health sector. But in the health sector, we acknowledge and appreciate that the identified individual level data is also very strategic data. And we need to legislate on it, ensure that it is being used in the right places and for the benefit of Wanjiko. So that she gets her services, quality services. It is in the Data Protection Act that the rights of a data subject are well outlined, and the term data controller and data processor are seen for the first time in matters health data. Today we celebrate 9 months since the Digital Health Act and the other 3 laws were assented to. It's been a whirlwind of activities to try and make sure that now this act is operationalized, and I will be sharing a bit about the regulations, the draft regulations. Of course, we know the Social Health Act already has its regulations that were published a few weeks back. So we like to talk about the Digital Health Act just for us to really appreciate where we are coming from. So it is this act that establishes the Digital Health Agency that we've alluded to earlier. It is this act that establishes the administration of the comprehensive and integrated management system, provides a definition of what is health data, and recognizes health data as a national strategic asset. Hence, we have the health data governance sections. It also brings in the biggest fear that people have when it comes to their health data. Is my health data private? Is it secure? And hence, the biggest part of this act is the part that speaks on confidentiality, privacy, and security of data. Then we have a section that speaks on digital health service delivery. How are we going to deliver services using digital health? So EMRs, EHRs, telemedicine, they're all mentioned there. And then we have, as part of responsive legislation, e-waste management. We are going to be having a lot of gadgets out there. What happens the day the gadgets can no longer function? We need to have a proper e-waste management system in the health sector that ensures the various R's like recycle, reuse are adhered to. And then health tourism. We know that there's a lot of health tourism. There's a lot of movement of data out there to India, Germany. Excuse me. How is that done and in a proper way? Excuse me. So this is a slide that just elaborates how technology transforms healthcare. And I would like you to zoom into mobile health apps. As I said, we are moving more from a curative to a more preventive, promotive. We expect to see a lot of mHealth apps coming up that will promote self-management, disease prevention, and early detection. Then move to things like data analytics. We are going to have big data sets, and we are going to be relying on a lot of competencies, both locally and international, to be able to analyze that data to gain insights that inform policy, program, and resource allocation. And then our most recent discussions, everyone is talking about it, AI, machine learning. This definitely will be something that will come up. The more we have a lot of data on people, we will now be moving towards personalized treatment plans. So because this is a HIV summit, I want us to now just take a walk to really understand why we need to do what we are doing. So we want to move from this level of data. So this is where we are at, been getting a lot of aggregate level health data, and people like Songok can remember that by the time we were coming up with this kind of age bands, we were moving from the age band of less than 15 and 15 and above. But then now people started saying, no, adolescents, they're the ones, adolescents and young adults, that's where we are seeing a third of new HIV infections. We need to see more stratified, disaggregated data, and hence we got all those age bands. But what does this mean? That our registers became bulkier. Our registers became had many more columns, and reporting became, discounting from the registers to the summary forms, MOH 731s, became quite a task. So we want to move from there to be able to move to the, individual level data. And this is what individual level data does. So in the previous slide, you can only now tell that a lot of the HIV positives, if you look at even the age between 1 to 19, that many of them are within the ages 1 to 9 and then 15 to 19. But within 1 to 9, are you able to know whether it's the really young babies who have been diagnosed to be positive, or is it the much older children? So when we have the identified individual level, or rather individual level data, we are able to then now see that actually, when you look at positivity, we are getting a lot of positives. We are diagnosing them. The children who are positive, we diagnose 0 to 2 years. But you can see we are still diagnosing some 2 to 5, 5 to 9, and assuming that this transmission is more of mother-to-child transmission, we would want to identify positive children way earlier so that we are able to put them on treatment and they are able to live quality lives. But you can see we are diagnosing some quite, late, if you now even look at the absolute numbers. Now, a few years back, we started this time to start ART. We moved to same-day start. And we kept on wondering, are people adhering to the guidelines? Are health facilities adhering to the guidelines? When you have data within a system, digital health, then you are able to monitor such things. But if we remain using what we have been using, our manual systems, then you are not able to monitor such things because it would need you add columns, more columns in the register, which at some point now becomes impossible. But if you have this system within some technology, some digital solution, then you are able to say, oh, so it looks like 80% of children and adolescents living with HIV are being started on ART on the same day. But we have about close to 1,000 who are started way beyond after 30 days. So you are able to ask, so what is happening? And this is something you can do even at your facility. So in terms of the system, there's been this fear. What does a system mean? Does it mean one point of care solution? No. It means that we recognize that there are very many point of care solutions, right from ECHIS at the community level to what is being used in the facilities. And then we also have what KEMSA uses in terms of their HPT. We have data from, systems like now under Social Health Authority. That is what makes it comprehensive. But what makes it integrated is what we call the health information, the Kenya Digital Health Superhighway. So in the center of this slide are two rectangles. And these two rectangles is what makes the system an integrated system. So around it are what we typically have in terms of the health sector. So we have point of care solutions right from the community to the facilities. And they are there on your, is it left or right? And then we have the regulators' data because we want to make sure that the healthcare worker seeing you is legit, is licensed to see you. We have the HPT suppliers like KEMSA. We want them, KEMSA, MEDS, and others to be able to even do F&Q from a national point of view, and even do track and trace. Any medication that's coming to the country, it be scanned, and then it can be tracked all the way to the person who finally receives it at the health facility. Then, of course, we have the health insurance providers. SHA is the biggest, but we also know we have private insurers. And then up here, we have the patient portal. One of the things we really want to do through digital health is to empower our people, empower the communities to take charge of their health. So several things will be happening at the patient portal, but one of the things is that each person will have that one health record and they can be able to access it. They can be able to also get messages on health promotion. They can be able to monitor even how their contributions in SHA, where they are at in terms of contribution. If they go to a health facility, they should be able to monitor when their claims have been done. And then, of course, the analytic component. So, and then we have the infrastructure, which is down here, and the cybersecurity. In between is what is going to make these systems integrate. So we have to be able to identify somebody uniquely. That's why you see the Kenya Client Registry. You have to have legit healthcare workers seeing us through the system. That is why we have the Kenya Health Worker Registry, legit health facilities that are known, the Kenya Community Health Unit Registry to update whatever is happening at the community level, a common language, that's why we have the terminology services, and that even includes the product catalogs. And then I mentioned that every Kenyan, we are going to have one Kenyan having one health record, and that is under the National Shared Health Record. So how it will work when you are seen at the point of care, there are certain data variables that are lifted that go and settle in the National Shared Health Record, such that when now, if you're in Mombasa and you're unwell, your record can still be accessed and the healthcare provider can continue care. So that is what it means. So we know we did a health facility assessment or census last year, and we were able to assess about 12,000, slightly above 12,300 health facilities. We expected to reach about 15,000, 14,000 thereabouts. We reached 12,000. Out of those, a third have the end-to-end health information system. And then we have some that are program specific, like now the HIV specific, HIV are program specific. We also know that there are non-communicable diseases non-communicable disease specific EMRs. So what we are saying is all those 12,000 facilities eventually will have to be digitized. Why? Because if you're going to be claiming from SHA, then there's no allowance for a manual claim. You have to do an e-claim. And I'll be talking more about that as we continue. So we have from the Digital Health Act, we then now have the regulations. These are draft, and we have had involvement of counties in this, involvement of digital health stakeholders, and we have three. Initially, for those whom may have been in the process a bit earlier, it was one regulation, like an omnibus, but the guidance from the AG is that we need to separate them. So we have separated them as per the way it's provided for in the Act. So we have one that talks about e-health applications and technologies, another one that talks about data exchange. For you to join the highway, what do you need? You know, for the expressway, we say you need a car, a vehicle that is registered by NTSA, that has a number plate, that the driver has a DL. So for a point of care solution in a health facility, what does it need to be able to get into the highway? And one of the things is it needs to be certified. And then we have a regulation that speaks about the information that is collected within the system. How is it going to be managed? So we have these two documents. They are part of the documents, critical documents that will be endorsed in the coming few weeks, because they go hand in hand with what is in the regulations. We held their endorsement so that whatever is in the regulations can match with what can align, or rather they can align with what is in the regulations. So now we think we have a pretty good draft for the regulations, and soon you will see the call for public participation. So in terms of, because I know counties are heavily represented in this meeting, what are the implications? So to a county, as a county health leader, the first thing is to understand that the CC is the health data controller and need to register with ODPC as a data controller. But beyond that, ensure that whoever is processing personal data in their jurisdiction registers with the ODPC, because we have like community health promoters. They are collecting a lot of personal data. Are they registered as data processors? A data processor is one who collects personal data on behalf of the data controller. Then ensure that the systems that are in the health facilities can share the minimum data sets with the National Data Bank, which is really can share so that we have that one health record for every Kenyan. Establish county health data banks. So there are different ways of establishing this. You already could have a data warehouse. That data warehouse needs to now be designated as a county health data bank, and we have provided in the regulations how that should be done. Or maybe it's too expensive. You ask the national government to figure out whether they can give you a drawer. I like to call it a drawer in the bigger national data bank, and then we call that Uasin-Gishu, for example. Then enforce operational level data protection procedures by being the CEC being the health data controller. There are issues to do with health data breaches at that level. They are the ones, the first level of accountability. So they have to ensure that data privacy is upheld, that whoever needs their data, let's say as a data subject, I need to move to another health facility, maybe they need a manual, something in terms of what happened when they visited a certain facility. The Data Protection Act provides for this should be done within a couple of days, and we have outlined all that in the regulations. And then I've talked about facilitating the registration of health data processors. Then the other big thing is build county level capacity for data management, including upskilling of certain cadres, like HRIOs will need to be upskilled at that level. The facility HRIO will need to, because now a lot of what they have been doing, the counting from the registers, is going to be done automatically done through the system. But they need to now be empowered to be data managers, to be giving insights at that level. What does this data show? In terms of the system, so collaborate with MOH and relevant stakeholders to establish health facility digitization. So as a CEC, as a COH, County Health Director, do you have a listing of all your facilities? Do you know which one has an end-to-end health information system? Do you know which one has a program specific, and therefore we are saying should now that we don't want program specific, we don't want corner kind of implementations, we want facility wide. Do you know what that means? How many computers do you need to add there? Okay, which are these facilities that are totally manual? Okay, if today we provide devices, are you able to start offering services through a tablet at that facility? Now we will be saying there's no internet, we need bundles. And then which are those facilities? Totally, it may take 3-4 years before digitization reaches them. How are you going to claim from those facilities? Because we said e-claims is one of the things that the SHA provides. Indicates that has to be done. Because there will be a woman who has a SHA card and she visits that facility and doesn't expect to pay because it's primary health care fund. So how will that facility claim? Then digital literacy for the various stakeholders along the value chain at that level. Then we talked about certification. So one of the things the Digital Health Agency is going to do is regulatory. Certification status of digital health solutions need to be done. As a CEC, you need to ensure that in the first 1 year, it will be a bit relaxed, but after that, it is only certified systems that will be getting onto that highway. So you need to ensure that that happens. Otherwise, people will be going to a facility. That facility cannot connect to the highway, therefore cannot identify that person uniquely. Then facilitate onboarding of respective health facility digital health solutions into the health information exchange. So I've talked about that. I've talked also about the importance of capacity building of the human resources for health for digital health. And then collaborate in updating selected registries. Like now the health facility registry is a dynamic registry. We want health facilities to be updating a lot of their administration data in there so that we are not doing what we were doing during COVID, using Excel sheets to report on number of ICU beds. That should be done automatically. So we know this is a lot of work, but we appreciate that this far we have reached is because we worked, several of us. We have a HIV program, private sector, that were early adopters of digital health, and we have a lot of lessons we have learned, and we are now hoping that we can, together with the other digital health stakeholders that are coming on board right now, that we can work together so that we work far. And lest we forget, the reason why we do all this is to improve quality of the data collected so that it can translate to improvement in quality of health services provided and a formulation of sound policies and innovation. Asanteni sana.
Thank you. Thank you so much, Dr. Wamishu, for walking us through what digitization really looks like. I think for me, my takeouts is from Dr. Wamishu's presentation. I think she's laid it very clear. The legal framework, the policy framework is in place. She's taken us through how technology is transforming healthcare, the ability to drill down and identify individual level data, and also spoken about the digital health superhighway. She's spoken how comprehensive it is in terms of the various pieces that connect, but also the integration aspect of it, but also the how to join this highway. I think we've all heard that there'll be certification in terms of how you plug into that, and the role of counties, which is very critical. And at the very tail end of this session, we'll be hearing from 2 counties in terms of their digitization journey. And I love her last point on challenging us that as we think of digital systems, let's move away from disease-specific systems. We are dealing with one patient. So let's look at facility-wide systems that are patient-centric. So Asante Daktari, I hope you'll stay to the end because we'll have a panel session to take in the questions. Our next presenter is a familiar face to this summit. It's around integrated information management systems and surveillance by Dr. Lily Nyaga from NASCOP. And Dr. Lily was here, I think, on the first day, and she really gave us granular data in the HIV space. And as we all know, that HMIS are a key building block for successful and sustainable HIV response. The WHO defines integration as a coherent set of methods and models that creates connectivity, alignment, and collaboration within and across the QI and care sector in health. Now, to lead us into that discussion, Daktari is already here. Let us encourage her with a round of applause as she takes the mic.
Come, show me. Doc. Okay, cool. Is it on? All right. Good afternoon. Yeah, once again, I have to, every time when I go to a space like this, I have to adjust to bring the mic much, much lower so that then I can be able to utilize it. So I'm happy to be sharing reflections and insights from the HIV program as a program that, as Joyce has called us, early adapters, as a program that has really, traveled the journey of implementing digitization. I think we have a lot to share in terms of lessons, in terms of the mistakes that we have made, so that then we can have you learn from us rather than make your own mistakes as we move towards the journey of integration. So my presentation is, I'm going to give you the background in terms of how disintegrated our systems currently are, so that because then that gives us the background for how then we want to move forward. I will also share a bit of information around the ongoing digital transformation within the ministry and of course specifically within the HIV program. Talk about the enhancement that our systems have. Of course, I cannot complete this conversation without sharing some bit of insights from what we are doing within the surveillance system, and then we can look at the next steps. All right, so how disintegrated are our services, which of course would also mean our data. I think it's very clear for us how the system is currently implemented. Yesterday, Prof. Kimayo, I think in his opening remarks, he did mention that disintegration was good at the time when we were really in that epidemic mode and we were in a rush to really combat the epidemic. Many years following into the implementation of HIV program and the maturity that the program has achieved, I think then calls for us to now sit back and rethink how we want to move forward. So we are not saying that the disintegration was a bad thing. We needed to actually verticalize the program. I was telling someone like a few years ago, and Prof. Ndwati remembers this story because I've said it somewhere else. I ran breathless, and within an hour I had arrived at Aga Khan Hospital. Between entering the hospital and 1 hour later, I had moved from saturation rates of 94% to around 70%. I was on oxygen. That was COVID. We buried like 3 or 4 of our relatives within a time period of around 1 month, because we were spreading it among ourselves and we didn't know, because my uncle had earlier been diagnosed with what they call diabetic ketoacidosis. For those who know, a patient would present with symptoms of being breathless. And so because they were non-diabetic, they were diagnosed as diabetic ketoacidosis. Then they died. Then we buried. Of course, we were using the mic. I was reading the eulogy. 1 day later, I was breathless. If I was to now be integrated, I was just imagining if there was COVID integration at that time. You can only imagine. Who would be telling you about this data? Okay, well, maybe somebody else. Could have been someone else, but that wouldn't have been me, because I would have died in the spirit of integration. So integration was, the disintegration was not bad at that point, but now we really want to look forward in terms of how we want to move forward and also just sustain our systems. So this photo here, I don't know whether it's visible. You can see the green. So the red, yes, so the red thing there shows, so this is Kitengela Health Facility, and that is the OPD in red. And many miles further on is where our CCC is located. And that is really, I think, the model for most of the facilities in terms of how the HIV CCC clinics were really established. Why is it not moving? All right, so I think people like to use this name Wanjiku. I don't know where it came from, but I shall proceed on to still just ask you to consider Wanjiku, who is a HIV patient, HIV positive client, and is also hypertensive. So would like to, find their records within the HIV clinic and also in their hypertensive clinic. So when Wanjiku goes to MOPC, where they are being seen, someone will need to go through this whole big bulk of files to really look for Wanjiku's file. I'm sure there is a format. Maybe they will ask for her first name, and then they look for a column for a place where there are files for people who start with, maybe say she's called Lily Wanjiku. And so by the time she gets her file and starts now to move from one service delivery point to the next, you can imagine what she has to go through. On the other hand, on the right side, in the HIV clinic, Wanjiku, we already even aware today that Wanjiku will be attending the CCC clinic. So the records have been pulled out from the system just by a click of a button. You can see the room is much, much neater. I bet the patients in HIV clinic will not be coughing as much as not the patient, but rather the healthcare workers in the CCC will not be coughing as much as the ones who have to deal with pulling out these files that are full of dust on the left side. So, and that's really what it means moving from manual systems to non-manual systems. Oh, sorry. All right, so that really was just to demonstrate where we have come from. And I also know there is also a few facilities that are still having to deal with this level of manual records within the CCC even in some CCCs compared to the very fully digitized facilities. Okay. Okay. So the journey of digitization, as earlier mentioned, early adapters. So most health facilities have their facilities digitized, especially on two areas. One is the CCCs, and the other is within billing. And I know our county directors and our CCCs will agree with me that I think if any facility that is fully manual has just one point of service that is automated, and that is where, where the money is, because we all want to be able to track how much revenue we are collecting, especially in this day and age. So MOH is leading the digitization agenda, and we are now looking to see, that coordination and leadership from the ministry in terms of being able to upgrade facilities to fully adopt digital services. Of course, there's someone who said that a clever man learns from their mistakes, but a wise man learns from other people's mistakes. So we are here as a HIV program because we have learned, we have made quite some mistakes, we've celebrated quite some successes, and we want us to be able to really utilize and leverage those lessons that we have to be able to support the broader ministry as we go facility-wide integration and digitization, so that then we can be able to sustain the investments that have been gained so far. So in terms of data, also we have come from far. Joyce has attempted to demonstrate the manual data collection, data compilation, and also just reporting to KHIS and what it takes, being able to sort of like aggregate our data into some big bands, so that then we are also minimizing the burden on healthcare workers. So, and I will be sharing our journey, the HIV digitization journey, because then you see that the motivation behind digitization in the beginning was not really around the patient, but rather as an imperative to be able to minimize the burden on healthcare workers, especially for reporting, as opposed to really being around the patient. Of course, the last statement around fragmented systems or fragmented data systems they are quite obvious. The patient who is a HIV patient has their data in EMRs within the CCCs, but when they go now for their other chronic condition clinic, then they have their data somewhere in the files. And even closer example is a CCC client who gets pregnant, and so is transferred to the PMTCT clinic and within the NCHs. And so they leave their record at that point, and we sort of like lose out for quite a number of clients for 2 years when they are being followed in MCH, and then manually, and then they are brought back. And that's why we have really been pushing for fully adoption of digitization within the clinic. So why are we having this conversation? HIV still remains a public health threat. I think in the first day we did discuss about these numbers. 1.35 million people are currently on ART, leaving us with around between 100 and 150,000 yet to be diagnosed. Our new infections having come down considerably, but still remain high at 22,000, and AIDS-related deaths at around 18,000. We did talk about our changing dynamics for our PLHIV in terms of having majority of our clients being much older and aging. And we know that generally, even in the absence of HIV, aging increases the risk of acquisition of non-communicable diseases. We did highlight 3 key conditions. One was hypertension, whose data, according to the data that we have, is around 7%. Diabetes, which was slightly below 1%, and CA cervix. But of course, we do take note that the data is not complete, so a lot still needs to be done. So when the young people were speaking to us here, they did mention that they all gave their definition of integration. And you can agree with me that the definition of integration is as varied as the number of people in this room. Do you agree? Everybody has their own understanding. There are people who actually think integration should be bringing all the services that are in the mainstream facilities to CCC. And there are those who think that it should be removing them from CCC, taking them back to mainstream. Which one is the correct one? Is there a correct one? Okay, we shall be having those discussions. And I think the service delivery team tried to unpack to really demonstrate what exactly would be the ideal. And of course, we were informed that our responsibility is really providing standards and not as much as being very prescriptive into the innovations that facilities have. So now I want to just share very briefly our journey towards digitizing HIV clinics, HIV services. So many years back, around 14 years back, it marks the year 2010 marks the inception era, so initial digitization. So this was an era that was characterized by multiple, siloed, small, how do I go back? Short-lived, help me to go back, Victor. So small, siloed, very short-lived, disparate systems. These systems were motivated by various things. Key among them was really to just be able to have the data, being able to access the data nationally or at a place where you are seated to be able to see what was really going on. So these systems were not based on standards. It was just those innovations. I'm in a facility, I'm desperate, I need to see how many patients I'm seeing. I create like a small thing. Some were Excel sheets, some were access-based things. So all these things were really, the start point for digitization. Then, of course, a few years later, 5 or 6 years later, we started to standardize tools. So here we see the ministry stepping in to start to develop standards so that then we are able to actually have these systems in a standardized manner. So we started seeing EMRs that were largely supported by PEPFAR funds. It's at that time when we developed the blue card. Was it blue? The green card. The blue card, which of course later evolved to become a green card. And this was really like the basis now for the encounter between the client and the patient. So at this point in time, we have around 700 DMRs. We start to see standards, but also still largely driven by the need for data. So what was happening is that clinicians would see their clients on paper, and then somebody much later would sit down to enter data retrospectively, so that then at some point they're able to click and say, we have this number of clients. So it was not helping in terms of the primary responsibility or role for digital systems, which is to really provide quality care to our clients. So we start to now transmit this data longitudinally. So we do have the data at the warehouse for a few EMR sites. Reporting rates were also very poor at that time. We started to utilize the data to do like cohort reports. But then at the client level, within the facilities, we were still not reaping quite some good fruits. We took a step back, and we now brought the clinicians on the table with a patient-centric approach. So, looking at the workflow, looking at, just how the system would really fast support the clinician to offer the right services, quality services. So issues around the alerts and the flags that people call clinical decision support came in, and now the clinicians were able to actually appreciate the system. And we started to see a lot of clinicians taking it up in terms of offering point of care services. When we look back now, the current situation we are in right now, we have more than 91% of all our PLHIVs being seen in an EMR. We have that data, all of it being reported to the warehouse. As a program, we have moved, collectively to really leverage the individual level data to provide insights in terms of, how our clients are doing, making decisions, and also coming up with analytics that are supporting us to be able to also drive policies and guidelines. So you can see that journey has been a journey of, a few mistakes here and there, quite some successes, and so we really pride ourselves in the fact that we are now looking forward to, really being able to embrace now the facility-wide EMR so that we have a holistic picture of what our clients are really going through. Of course, I should be mentioning some of these other solutions like predictive analysis, the AI and machine learning that I also mentioned in the beginning. So, has digitization worked for the HIV program? I think we all know the answer is yes. We, as I've mentioned, we do have quite a number of facilities. Out of 3,500 facilities that offer HIV services, around 2,200 facilities are using EMRs. So services are automated clinical decision support for the healthcare workers, and so seeing better outcome for our clients in terms of we're able to flag patients who are not suppressing, flag patients who are due for a viral load, and so we are able to actually support them. You can see how the EMRs are distributed across the country for reasons that are best known to you. So in terms of who owns the EMRs, majority of the EMRs are actually actually in GOK facilities, slightly over half of them. But we also do have other facilities like the faith-based, private, and other sites. So because I see most of you are on your laptops, can you quickly go to the data warehouse? I just want to make sure that you get to understand what this elephant is. So DWH, let's go. www.dwh.nascop.org. Anyone who's been able to access it? You have. dwh.nascop.org. So obviously, services, data, the first point of collecting data is really at service delivery. So we have data being generated from the testing points, the care and treatment lab, pharmacy. So all these data is also able to communicate, and I think Joyce has brought out the issue of interoperability and the fact that we are not pushing for a one common system. All we are saying is that can these systems that exist be based on basic standards, and also can they be able to communicate and exchange data. So we have multiple platforms like the MLab for for lab requisition. We have Ushauri for conversing with our clients, and also reminding our clients to come to the clinics. We have our ADTs that are helping us with inventory management, being able to communicate with the EMR, specifically the Kenya EMR. So people who are tested using a mobile application, the EHTS app, all these data will be available. It's communicating with the multiple other data to be able to give you one full record, pushes this data to the warehouse. Have you been able to enter the warehouse? And you can see the basic analytics that are coming from individual level data, which was not possible at the point when we were largely relying on the aggregated data. Of course, the aggregated data has its place. We are not saying that it doesn't have its place. It does have its place, but there is the benefits that are conferred by having individual level data. So the warehouse hosts, as I mentioned, around 94% of our data. It's longitudinal from when the client was diagnosed, following them on up to death. And of course, at the very end, we have said that data must go beyond just the primary use of clinical management, but also to be able to, on a secondary level, to be able to help us to do analytics that are driving the policies and the decisions that we make. So we do have a lot of analytics that were shared on Monday. We are also now doing surveillance, case surveillance. We're also tracking multiple events for our clients, and also to the very end, monitoring who is dying and why they are dying. We also do receive quite some requests for data for people who are doing research. Some people are also doing their masters and PhDs or postdocs using the data that is currently within the warehouse. Okay. Okay, so I just want to share one use case for the longitudinal follow-up of our clients. So in 2022, we initiated on treatment around 90,000 clients. 82,000 of these clients were initiated through an EMR, so we did get their data into the warehouse, which is close to 95%. So we can actually say that this data is highly representative. So of these clients that we started, we were able to have around 7,000 were transferred out, around 3,000 were reported to have died over 2 years, and around 10,000 were reported to have interrupted treatment at some point. So that's translating to a retention of around 83%, but you can actually see the insights around having that individual level in terms of seeing the outcomes for our clients. Where am I supposed to be pointing? Okay. So I will also be just showing you a few case studies around NCD co-infection and also COVID vaccination. So this is the same slide that I shared on Monday in terms of how many clients have been screened, around 60% screening, people who with suspected blood pressure around 39,000, those that have been screened for diabetes around 300, cervical cancer screening, similarly, just as shared in the last presentation some times back. Of course, being able to now draw insights, our responsibility as SI is not just to give you and bombard you with information, but rather also to give you knowledge, not just giving you data and saying we have more data, Mingi, we keep asking and starting to add more variables, but we are giving you information and knowledge that provides insight as to what is our data telling us about our clients that can help us to do better for our clients. So for example, I did demonstrate the issue around control for the NCDs versus control for HIV, and we did see that there is a discrepancy in terms of people being very well controlled for their HIV disease, but then poor control for the NCD, both diabetes and hypertension. So this is really going beyond the HIV programming for our systems. So we were able to collect data for COVID vaccination in the year 2020-2021, and we were able to actually see who is getting vaccinated, what are the trends, or the patterns between gender and between age, and you can actually be able to see that the people that were largely targeted for vaccination, majority of them did receive, and we could be able to characterize for you who are these people who are either refusing to be vaccinated or are really not receiving the vaccine. So why should we integrate? I've already mentioned that we have lessons that we have learned over 15 years of digitization. And so we really just need to be able to support as we are moving forward in terms of opening up to their facilities. Kenya EMR has now developed a sector-wide EMR, and we are actually able to follow our clients end-to-end, if I were to use that word. And of course, this could not have been possible without the leadership from the ministry. We do have now unique identification, which is, I did mention in my presentation earlier, which has been assigned to more than 95% of our PLHIV. Of course, the issue of service continuity cannot be overemphasized, and Joyce did mention around claiming and claims for the incoming social health insurance fund. Okay. So I think I will allow me to skip the superhighway because Joyce has done due justice to it in terms of just showing how the different platforms will interact with each other and where they will intersect. I think this was well discussed by Dr. Wamishwe. Similarly, I think it's really showing, because remember at the sector-wide or rather facility-wide EMR, we are starting to digitize from level 1. We already have the ICHIs, and then now we have information flowing from the community to referrals to the facility, and then referrals between facilities or referrals upwards in terms of levels. And so we are going to be able to see how Kenya EMR then is going to support these movements and communication between the different layers and levels. So in terms of the ongoing digital transformation, several factors are going to really support this transformation agenda. So one of them is the unique patient identifier. We do have a NUPI that has been assigned to nearly all of our clients. Of course, Joyce did allude to the fact that this data has to be shared between facilities, between healthcare workers themselves, and also just also being shared across the different levels. So, and this has to be done in a way that is secure and that also assures privacy for the clients. Supply chain and HPTs, we do know that this is one of the big elephants. We had that discussion yesterday in a panel that was full of men. And so we know that this is very important. And of course, the e-claims, as has been said, we need, by uniquely identifying the client, the facility where and the healthcare worker that is offering that service, then you're actually able to claim and show validity in terms of that this service was indeed offered by this person in this facility, and so then they really deserve to receive their claims. So, we currently have Kenya EMR approved for facility-wide digitization, and we are now able to interoperate between different systems, then therefore facilitating health information exchange, which means that the patient may be seen in any department, our HIV patient, and the patient can move freely across the different facilities or different healthcare workers, and we have that information still being visible to us for better decision making. So how has Kenya EMR integrated for service delivery? I think I've mentioned that now we are ready for to be able to offer non-HIV services. We also have the additional functionalities around billing, M-Pesa, and all these other things. And then, of course, commodities, both HIV and non-HIV commodities. Going beyond the HIV services and being able to go to specialized services, and I'll show you some of the modules that have been added to that module. So this is what I was talking about, referrals from ICHIs. So as you can see, there is a tab there around community referral. So you're actually able to see where the client is being referred from and why the client is being referred. And so you are actually able to initiate treatment and follow up from that point. In terms of billing, you can actually see a tab where the client has the entire of their history, and then they're actually able to be prompted to make the payment, and hence that record is going to be available. So I'm being asked to really move slightly faster. Kindly allow me 3 minutes to just complete. So in terms of the functionalities of Kenya EMR, we do know that we have the common services around registration and queuing, which are important, and of course managing appointments. We do have the facility, the administrative functions, billing, medication dispensing, the reports, clinical decision support, as I mentioned, flags and alerts. Maybe just highlighting the specialized clinics. So you actually, for whichever clinic you want to go to, you're actually able to access it, of course, in addition to the diagnostic and the general medical services. So within the Kenya EMR, you can see at clinical views, you're able to actually see the specialized clinic. You click. So basically being disease agnostic in terms of the system, being able to allow whichever disease the client is being followed up for. So this is really just to show, chronic care, follow-up, and just being able to see that the client is a diabetic client or a hypertensive client who's on nifedipine, and these are their vitals. Surveillance. I think the role of EMRs should be able to allow us to do either active or passive surveillance for our clients. So for disease surveillance, we do have reportable diseases. And so what the EMR is able to do for us is that as you're entering the record for how the client is presenting, you're actually able to pick. The system is able to pick some symptoms and classify the patient as either having a suspected condition. For example, in this case, after entering the clinical history for the client, the system was able to say this is a suspected dysentery case, and so it's actually able to report, give you a line list, as you can see, of all the cases, and then you can actually now go further to be able to investigate and see whether you truly did have an outbreak or not. So, okay, I did talk about the inventory management in terms of, being able to locate your stocks, to monitor them, and get insights. 1 minute to now share something quickly around some surveillance ideas that we do have. Okay. So purely, 1 minute actually. So for surveillance, you do know that surveillance and survey platforms have traditionally been vertical in nature, and this has similar to what we do for our programming, and this has resulted in standalone surveillance and surveys that are one-time use, very expensive, and not sustainable. So one of the important qualities of a surveillance system is flexibility, to be able to add new and emerging public health concerns, leveraging on the same staff infrastructure, and therefore becoming more sustainable and in terms of the cost. So we have suggestions around how we would want to leverage the existing symptoms, and I'm glad that, the existing infrastructure, and I'm glad that the NPHI team is here, and we have been having discussions around how to sort of start to integrate multiple systems. For example, DHS is done every 5 years. Most of these, DHS and KENFIA, usually they're done a few months apart, going to mainly maybe the same people, and of course they are national. Malaria indicator survey as well. So what stops us from actually adding 1 or 2 indicators, say in a DHS, collect malaria, collect something around HIV, and just have one integrated population-based survey where you're leveraging the laboratory infrastructure, the staff are the same, and therefore making it more sustainable. Okay, so in terms of the biorepositories, we actually have a situation currently ongoing. We do have multiple freezers that have been put in the different labs, storing samples, awaiting to be destroyed so that we can move on to the next. Why can we not integrate and utilize the same resources? So we are actually having a conversation with the KENFIA team, coming up with a collaborative framework to see how we can start having the samples being put out there for multiplex testing and just going beyond your routine HIV indicators. I think the role of DSS and just being utilized, leveraging the demographic surveillance sites to actually either maybe do a follow-up for PMTCT indicators, determining transmission rates within those sites, that could also go a long way. And of course, mortality surveillance and recency surveillance to provide signals for how we are moving forward in terms of emergence of diseases. I think I will leave it at that point because I have been told that I need to stop. But I hope I have been able to demonstrate that systems can be integrated to be able to go just beyond the routine service delivery, but going beyond that to provide public health monitoring, opening up channels for empowering clients to be able to also take that active role in their health management. Of course, the issues around reimbursement and research and innovation. Asante.
Thank you so much, Dr. Lily. I think you can tell and feel the passion as Dr. Lily speaks, so we'll bear with you with the overrun on time. I think it was really exciting to just hear from you the HIV digitization journey and the need to safeguard and preserve the investments that have been made, and also use the learnings as the early adopters of digitization to scale beyond the HIV space. Thank you for affirming that digitization has worked for the HIV program, really addressing the why and the so what of digitization. Thank you for that. So our next presenter, and I know we are quite behind time, we've heard from the national level issues of governance and where we've come from. Now we want to go to where the rubber meets the road, at the county level. And we do have some frontier counties that have done a fantastic job in terms of digitization. So I'd like to invite Dr. Bernard Wesonga to share his perspective from Kakamega. Dr. Bernard is the CEC Kakamega, and let's encourage him with a round warm of applause as he gets to the stage. Karibu, Waziri. Let's keep clapping until he gets here.
What do I do here? Okay, good afternoon. Good afternoon again. I'm told to take 10 minutes. As you have heard, I am Bernard Wesonga, the Minister of Health in the great rural county of Kakamega. Team Kakamega, where are you? I asked to recognize where you are. Team Kakamega, very good. Now, the experience of digitization has been heard from national government. And as well said, the rubber meets the road in the counties, and Kakamega has not been left behind, as you realize. Now, I believe I'm supposed to use this. Yes. Now, that's Kakamega. For those who don't know where it is, we are boasting a population of 2.1 million, and that's why it's the largest rural county in Kenya. 12 sub-counties, now 13. And of course, you can see we have quite a big number of facilities, over 200. The burden of disease, as you can see, we have got anemia. Now, you can see number 3, hypertension. Number 4 gives you the HIV-related complications. Of course, those was why in the medical field, we don't talk about HIV as a cause of death. We talk about complications. And then you can see the others following suit. You can see number 9, congestive heart failure. This is what Professor Kimai was talking about. Now, HIV profile, you can see we have about 48 people living with HIV, prevalence of 3.4, and people linked to care is quite a number, more than the people who are positive, and we understand why. The journey of digitization. The Spur Highway began some time back, and this basically traced back to electronic health records, as has been talked about by previous speakers. And our vision is basically to integrate end-to-end digital health solutions at all our facilities, taking into consideration Data Protection Act of 2019 and Health Act 2023. Why digitize? I think previous speakers have talked about it, and there's a lot of paperwork involved. For those of us who are already gray-haired, we have been dealing with the papers, like Professor Duarte here, for the last 40 years. We have been dealing with papers, and I think as we get the generation of today, we need to get rid of the papers. So the paper-based data collection is a big issue, and to say it plainly, there is no space to store these papers. And we have realized that when you digitize, you basically have more time for the patients. For those of us who are in the clinical sector, you find that eye-to-eye contact and time for our patients is the most valuable thing that you can ever give to a patient. And therefore, digitization gives that space to give more time to our patients, and then exchange of information between facilities, counties, national, and even outside. And of course, service integration. Now, I think the previous speaker, Dr. Lili Nyaga, has talked passionately about the EMR, which of course is an open system, and therefore very well accessible, and it can be expanded. And it's used in CCCs countrywide. Dr. Lili, thanks for that. This is a very valuable investment. And as you said, you can add any module to this system and it picks, which is very good. And it also allows for seamless data exchange. Now, we have a facility in Kakamega called Shibwe Sub-County Hospital. For those who are familiar with the county system, now this facility is a level 4 politically, but a level 3 technically. Those who are in the county, you understand what that means very well. And this facility was chosen because it's not a high volume level 4, so to speak. It's also not a less volume level 3. So it is in between. And it was basically picked up by Health IT. Health IT, our partner, Health IT. They have gone for lunch. We shall find you. Now, what was done actually is that the HIV management is very well resourced. That's why this sector you know very well. And data management is much better in that program. And we wanted basically to ride on the resources in the HIV space. And therefore, Lily asked which one is being integrated to what. For us, it's very specific. We are integrating HIV onto the other routine services. So that is clear with us. And therefore, we basically use resources from HIV to train healthcare workers dealing with other diseases. Then we basically transfer skills from the staff dealing with HIV to other staff. So we began with the skills, capacity building for other staff to understand what goes on in the HIV clinic. And also the staff who are dealing with HIV, they also trained to understand what goes on in other routine clinics. So you can see there's OPD, there is triage, then the system also has capabilities to add on more modules like queuing, laboratory, pharmacy, inventory, revenue, and I think revenue sounds very good for everybody, and some reports. So this system, as it happens in the CCC, that is the way it's now happening in the other, the main facility. So what have been the enabler for HIV the deliveries for the integration? As you can see, we have built capacity in HRH, as I mentioned, because the clinical officer who is dealing with the patient, the CCC, is the same one who, if we take him to the other OPD clinic, he's able to do the same thing. HPTC, now the pharmacy is one. We don't divide this, they need the pharmacies, so we only have one pharmacy, and therefore one pharmacist who understands both HIV medication, as mentioned by Dr. Lois here, and the common medication used. Then we have got call service delivery, and I think HIV gave us very good data and indicators of call delivery, which we are basically using. And of course, lastly, the information system that is now integrated for both HIV patients, our clients, and the other routine patients. Now, the benefits. There's support of site review and follow-up of the clients, saving on the fiscal reporting tools. Another module allows, for those of us who are in the counties, you understand what revenue means. The more the revenue, the more the flexibility. The less the revenue, the more you're caught up. Secure system with the privilege of access rights for the users, and then efficient management of human resources, that is staff rotations, as I said earlier. Enablers. Now, I think many speakers have talked about this a very important thing, about county leadership and ownership. This is where actually it all begins. Once you have the leadership that accepts that we need to move, not stuck in the old way of doing things, then that's where the wheel starts moving. And for Kakamega, I think the leadership is very much embraced by innovations, and we move with the times. Facility assessments determine infrastructure and capacity needs. For partners who have been in Kakamega, I think we insist on this so that we know where we're coming from. Gap analysis, the same thing. Responsibility matrix, again, that is, we always agree with the partners what is our role and what is the role of partners. There's no mixed grill there. Then ICT support, this one is very true because data automation must rely on software and hardware. And that infrastructure, ICT support is very important. And then power supply. For those of you who are in Mombasa or Nairobi, you may not know what that means. But those of us who are in rural areas, we know what it means. Power supply is a very big issue. And automation can't run without power supply. And we have made sure that this facility has persistent and reliable power supply. Facility ownership of digital health solutions. Again, our staff, our management, basically moving on to the bandwagon of automation, and we won't be left. And it never shows up, isn't it? Yes. Now Mombasa is suffering the same problem. Now you can see what that means. If this data was on and the power goes like this, you lose it, basically, without a backup. Oh, we have to reset. I should have come with a manual backup. Okay, stable power supply, there it is. We had technical assistance from our nascent local university of scientists, and we normally get a lot of support from them. Or it's time for lunch. Now, colleagues, you understand what it means to have ICT backup. Without this guy here, we are stuck, isn't it? ICT backup. Okay. I was just talking about the issue of our roles, which has gone near to the previous slide. The issue of the roles, the county health IT, and how that basically comes into service delivery patterns. Now, the next thing is, what are next steps? Now, as we move to the issues of PCN, automation and data management is very important. Just like as Dr. Lil mentioned, we need to have smart PCNs, meaning that we need to have information that is client-specific and client-centered. Now that we are recruiting people for social health insurance, now that we are not leaving anybody behind, meaning that we need to have smart PCNs that know each and everybody. Then AI. I think this was mentioned earlier on, but I just want to emphasize that from where we are going, AI is going to play a very big role, all the way from deep learning, machine learning, moving into AI, because once we have something like ICD-10 incorporated into this automation, and once you have all the symptoms of possible HIV presentation incorporated, then you find that the AI will come in with a lot of good things for predictive diagnosis for the people who are in the system. And also, it will also help us in terms of managing the patients to a level whereby we don't waste time, and therefore we introduce efficiencies and effectiveness into the system. So, colleagues, just to make a small rejoinder on national government presentation, Dr. Lily, I know, and Dr. Joyce, you have made very passionate presentations on what's happening at national level. I want you to remember that what is happening at national level should also be happening at county level. As you stand at national level and look at the counties, 47 of them, I'm standing at the county level and looking at 12 sub-counties, sub-counties in Kakamega to do the same thing. So for me, these good presentations that you have done from national level, I would like them to be replicated at the county level, because the Digital Act 2023 has basically designated the counties as, you have just said very correctly, as the controllers of data. That's right, Dr. Lily, isn't it? And therefore, this architecture I've seen here, I would like to have a discussion with you so that next time we are talking, you're not presenting it from Nairobi. You should be presenting it from Kilifi. That is what Kilifi is doing. That way, we are moving. Otherwise, centralizing in Nairobi alone, we are not going to move the way we would like to move. Lastly, I think there's something on research and data. The partners who are here, and of course my fellow counties, data is the next oil that we are going to fight over. And the counties are very well placed to make sure that they are the custodians of their data. And me in Kakamega, I always insist that when the researches are being done, the county has to be at the designing stage of the protocol or the proposal. That is the only way the counties are going to own the data. Because a lot of researches have been done, a lot of data has been collected. But every time we want to plan, we are still looking for the same data. Why? Because we don't own the data. Solution is at the design stage of the protocols or proposals. So there has been a notion that counties don't have the capacity to mount a research. That notion is misplaced. The counties have some of the best brains you can get in this country, because these counties, they are also connected to universities in their respective areas. And if we harness that capacity from the universities, put together with the counties, then we have a very big think tank in terms of people who can mount research. So, colleagues who are here today, my personal appeal on the side of the county is that the rain has been beating us on the issue of data. Let us not come here and talk very well about data management, then we go back and don't manage our data, we are going to come back here 5 years talking about the same thing. So let's take the bull by the horns and make sure that we own our data in our respective counties as the Act of 2023 has told us, because every CEC who is here in health, like me, you are the controller of data in your county. But not by name. It has to be by action. A call to action. All CECs must own their data. That's my call to action. If you call me here, if I'm still in health for the next 2 or 3 years, I want to see how many CECs will be owned there. Then planning will become easy. Then we shall come here and say, now we can plan our health sector very well, because you can't plan without data. Let's not cheat ourselves. It's not possible. You can't plan without data. And the colleagues who write for us proposals, and the partners of universities, they are doing this because they can access data and manipulate it. Lastly, one thing I want to comment on, which was said here, and I want to just repeat purposes of clarity. The HROs in our counties, HROs who are here, who are in the room, please cut up your hands. HROs in the room, very few. The cheese has moved. The cheese has done what? Has moved. The traditional way of keeping records is no longer tenable. So all HROs in the room, please enroll in data analytics and AI, machine learning, deep learning, and all that. Because as we automate like this, I want my HRO to come and tell me this is what the data is showing. Without that, again, how will I make decisions as a CEC? Is that possible? No. So, sorry, I've taken a bit longer, but I just wanted this to be driven home. Thank you very much for listening to me, and I just want to recognize Professor Kimayo, who has been a very good guru in this field, and Professor Ndwati, who was my mentor in this field. Dr. Wanene, behind there, from your side, he has left. Thank you very much.
Thank you so much, Waziri, and for your call to action. I think it's very clear. I don't need to belabor the point. CECs, on your? Thank you. And I think from Kakamega, as Waziri presented, they're using Kenya EMR. And just to go back to Dr. Lily and Dr. Joyce's comment, they're not being prescriptive. So we want to hear from one more county that is using a different system, and they've also had quite a journey in their digitization journey. Allow me to invite the County Director for Health, Murang'a County, to also come share their learnings and the journey with digitization. Dr. Mboro, karibu to stage.
Good afternoon, colleagues. I have the very difficult task of ensuring that you go to lunch in good time, and therefore I've been given 10 minutes, and I'll try to keep fidelity to that. My name is Dr. Mburu. I come from Murang'a County, and I beseech all of us, especially those from the counties, to give us a bit of an ear despite the rush. And in that behalf, I want to acknowledge my Casco, David, wherever you are. You can stand. I think David has done great work in this sector. And I'm very proud of what him and the team are doing. Murang'a. Are we moving? Yes, so I will very briefly take you through the outline of our county profile. the HIV situation, I may not talk much about it for now. I want to share one slide on the automation journey, and I think this will be very critical for all counties. We see what facility-wide and county-wide HMIS interventions mean, achievements, challenges, and of course, the opportunities going forward. The critical areas here to note on the county profile, even if we ignore the county population, look at the number of total health facilities, 244. Now, if you look at the second bullet from down, we have 42 EMR sites on the HIV field, compared to a total number of 244 facilities. We'll come to that. Look at the number of total county HRH, 2,500. Yet, the ones that work in the HIV field are 216. And these 216 are the ones who have been capacity built in terms of EMR in the HIV field. Yet, we started on a journey to take these 2,500 from Egypt, literally, in the digital space, to be able to have a facility and a county-wide EMR system. That is the county HIV situation. The red could be important as we run our program, because when we use the HMR, we are able now to have visibility in terms of, for example, the sub-counties that have not achieved the 95 in terms percentage in the viral suppression area. Now, this is the slide that I would beseech all of us to pay attention to, because it can help us and help you as you commence on the journey going forward. That we started on a roadmap guided by an investment plan, and we were very lucky because once the new administration came into place, and I think anybody talking from the county level will attest to this, every governor would want, for example, to track health products and track financial flows, isn't it? But the new governor came into office, and of course, he would also want to track commodities. He would also want to track the financial and revenue flows. And therefore, he looked for an avenue to get that visibility. And we sent out teams to various places to see what they were doing. And after a series of benchmarking activities, they settled on the AFIA KE as a ministry innovation from the Ministry of Health. And the journey started. Once we compared the other solutions, we settled on this one. But there was more to come, because most people assumed that this just meant switching on computers, and there we go. But it meant that we had to map all our facilities from level 5 to the dispensary. We mapped all of them in terms of service delivery points. We mapped the type of client flow, and that gave information on equipment need. Everybody thought that once we bought the computers, we are home and dry. But that was done. The next part of the triad was to identify internet service provider. And Safaricom came on board, was contracted to offer that. But the most critical point, and this is what I want to emphasize for all of us, even as we procure equipment, even as we procure internet service providers, the most critical element, the most critical component is the human resource for health. That is what will make or break any HMIS transition journey. Because you can imagine someone, the HRIUs or our staff who are in the deep dispensaries, someone who has been on a paper-based system for 40 years, and you want to transition them, and they are the only staff in that facility, into a HMIS. So in terms of behavior change, creating a buy-in, ensuring that they adopt to this, is the most critical component. That is the tiebreaker, and that is where you need to invest, both in terms of finance and capacity building. And therefore, we did capacity building for all our staff to convince them that this is doable. Currently, as we speak, we have automated the level 5 hospital. We have automated all 8 level 4 hospitals. We have automated all level 3 facilities, that is the health centers. And as we speak, we are completing. In fact, I think we have 5 to go to complete all the dispensaries. And this was then launched on 11th August by CS Health, Honorable Nakumincha, and Irungu Kangata, Honorable Governor, Muranga County. Therefore, this is basically to emphasize what I have alluded to, that you require the software. You require the hardware, yes. You require connectivity. And the power backup, we'll see it as we move on. But the software has enabled us, of course, to onboard all 157 facilities. This is still work in progress. We continue a progressive improvement over time. It has brought in visibility, especially end-to-end in terms of stock management, going paperless from outpatient departments to the wards. There is now real-time dashboards. Every medical superintendent in the county is able to have visibility. They are able to see client flow. They are able to see clients from registration to triage to service delivery points. They can be able to track revenue flows, revenue streams. And of course, we have now issues of patient records portability, like has been mentioned earlier. In terms of hardware, we have been able to procure through the ICT department, desktops, tablets, through the county government. We have also received support from some partners in terms of equipment. And I think at this juncture, I really want to pitch for that, because we still need more support in terms of equipment, and especially tablets now to give every health worker to be able to render this service. Key achievements, and I think I'm almost to the tail end. We have achieved so far, 1 year down the line, 90% rollout. There is now visibility through dashboards, and this visibility is not just by management. There is an executive dashboard where the governor is able to track all these activities. The hospital managers, from the nursing officer in charge, the medical superintendents and the administrators, everyone is able to visualize the workload, client flow, and the revenue streams for their respective facilities. We have also now onboarded recently e-procurement for pharmaceuticals and non-pharmaceutical products. Actually, for this one, and I think I would really urge all of you to look into that, we have even onboarded one of the KEMSA officers in one of our working groups to ensure that once requisitions are done at facility level, that there is direct linkage to the KEMSA systems, and in case of issues, there is someone to troubleshoot from the KEMSA side. HLH capacity building and buy-in, like I have said, very critical. Data capture. Some facilities have now documented that they were losing almost 50% of their OPD data. So even before we talk about data quality, even the crude data, we are seeing a lot of change. Some revenue streams have actually gone up by 50%. Then the most critical area that was mentioned here earlier is that it is good that you become certified, and this for Muranga we have achieved. We are certified as data processor and data controller by the data commissioner. So those two certifications arrived the other day. So that is a critical milestone, and I would, it's a critical area that had been mentioned by my previous speakers. The other critical area that we did, someone has said, the CEC Kakamega has said that the HRIOs better watch the space because the cheese has moved. But I want to encourage them that they have a very critical role. We mapped our HRH ecosystem in the county, and we identified HRIOs who had very strong IT backgrounds. We even had data clerks, ordinary clerks, but who had a big IT training, and we made them we made them champions in this sphere. And they are the ones who are supporting all sub-counties in terms of troubleshooting. They are the ones who are supporting this system, and they have also been capacity built by the MOH team. And therefore, everyone has a very critical role. It is just a question of transforming and adapting to the new roles, because we have to change with the times. Of course, online patient referral between facilities has been enabled. And the most critical, that is the last bullet. The governor kept asking, so what is in this system for the common man, the client? The clients are now able to onboard themselves by pre-registering on their phones, so that when they come to the health facility, you actually, by the time the records, people click their phone number, their other data is populated in that system. Therefore, the records and the triage system is more seamless, and basically we are improving on the turnaround time, and obviously the client experience. Because in health, we traditionally have run it in a very, health worker-based approach, forgetting that that patient is the client and the driver of this area. Of course, I think I want to, at the very early onset, throw some caution that every new system, even the Kenya EMR that has been there for many years, it is work in progress, continuous improvement. We have also had challenges, power outages in various health facilities, internet fluctuations, system downtimes, equipment, of course, we are not yet there, data quality and completeness issues. Of course, that is the next debate that we are having. We are collecting tons of data. We have now to go to the next step of discussing data quality. Of course, also onboarding this data to the KHIS, and of course, basically, when we started this, we also noted when it comes to data, especially programmatic data, HIV, TB, and GBV, remember these were now new staff who have now been given new mandate in this area. And therefore, we noted some data losses, and now that is what we are addressing. But that should not be a drawback to anyone, because continuous improvement can only happen once you roll it out, and you now notice the gaps, and you mitigate them. Network coverage, of course, in certain areas, but the beauty is this is good feedback to Safaricom, because now they are able to even tell where their net coverage is weak, and they work on that. Opportunities, very important. End-to-end visibility, and this even in the HIV arena. Now with the pharmacy team, they are able to track and monitor how the stock levels are moving. They can be able to tell which facility is having their stocks down, which area you are likely to get a drug expiring and all that. So they're able to track real time. Laboratory, when we started, and I think I need to also emphasize this, it was not, a very efficient system initially. Lab, once the clinician made a request, the lab still were uploading, were giving clients paper-based reports. But progressively, we have now been able to ensure that our lab equipment are interoperable in terms of the ones that have that capacity, and the lab personnel are able to upload results into the system for the clinician to see at the point of request. Also monitoring nutrition commodities. Of course, we are having discussions on the issues of interoperability between Afya KE and Kenya EMR. Like I told you, we have 46 CCCs where now we need to discuss that to ensure that clinicians are not doing double entries, and that will mean issues of ensuring we have a dedicated HIV module in the Afya KE. The other, of course, area is interoperability between this system and ECHIS because of the community strategy and the big army of CHPs and the data that they are collecting through ECHIS. We are also very strategically looking at issues of telemedicine. This is happening in the radiology area. Of course, we have teleradiology, but we are trying to see how else can we, ride on this to ensure that we are able to reach those far-flung areas. Our consultants through the PCNs, this is the area that we want to exploit to ensure that we roll out telemedicine and support our lower facilities. Linking of 4 types of medical and imaging equipment with the system. Of course, linking other third parties. And this social health insurance has been mentioned. And I know the claims will be online claims going forward. And therefore, we need to inbuild and on board this kind of capability so that, of course, issues of fraudulent claims will be addressed going forward. And therefore, it's an exciting field now because every of these organizations in health is digital. Alignment with emerging and evolving landscape. We are also very well aligned and alert about issues on the Digital Health Act, the Data Protection Act, and finally, the rights-based constitutional framework. We have all been told that the client has the right to their data, and of course, there is a huge discussion on that area. What are they able to access? What are the checks and balances? And then explore use of HMIS, like Kenya EMR 3.x, and we are aware of what is happening in that system, and we are positioning ourselves not to be left behind. This is my last slide. That is when the launch happened. That is the governor and the deputy and the honorable minister. And I think we also want to acknowledge these partners we work very closely with. And I think in this room we have LVCT Thibiti. We are leading in terms of conversations, in terms of service delivery and improvement. May I thank you all for being a very attentive audience, despite me standing between you and lunch. Thank you very much.
Thank you so much, Dr. Mburu. I really love the systematic approach to your digitization journey, right from benchmarking to selecting the system to adopt all the way to scale up. You'll agree with me, this has been a very enlightening session, a lot of learnings, a lot of call to action. Waziri from Kakamega also challenged us about AI. And as we think of AI, we also have to see the gaps because most of the data sets, the source is not from our settings. So I think also that's a conversation to take forward. How do we ensure that the AI tools that are being introduced in our setting has also been trained with data from this region? And I'm very excited because even us as an institution, as Path Kenya, we're embarking on work to really develop data sets and models that will be used to validate large language models. I know we'll be taking questions after lunch, but there is one pressing question from Professor Ndwati, and I'm right next to her. I cannot say no, so please bear with me, then after this we'll break for lunch. I think you can just...
My question is, the largest cohort of patients using the healthcare system are under 5s. My question is to the CC Buranga and the CC Kakamega. Given that you have this system, can you tell us who has been immunized and who hasn't? Which baby has been immunized and which one hasn't? Are you able to tell us about the maternal health? Who had eclampsia and who didn't have? That's my question. Second question. The EMR system is great. You're using it, it's good for money, collecting money and that kind of accounting. I engage with it as a clinician. The quality of data that you need to use for diagnosis that we are picking up from this EMR is worrying. So it leads to some delay in diagnosis. So that that question needs to be there to be considered as well. From the point of view as I'm a clinician trying to make a diagnosis of the patient. That's
Dr. Isonga, do you want to take that, and maybe Dr. Mburu, and then we wrap up?
These are very nice questions. We should be able to say which child has been immunized and which child has not been immunized. Let me say that crudely, from where we are, we can answer that this child is immunized and this child is not immunized. That's crude data. Now, this links to the second question you asked. What is the quality of this data? All of us who are in this room, from the counties and national, we all know that this data has not gone through rigorous, robust validation process. And therefore, as I said, Professor Ndwati, this is crudely, we can talk and say that, these are the numbers. But the solution lies in going back and interrogating our data through data analytics. The reason why I say this, I'm a clinician like you, but I have to rely on HRRO, who is now more or less like the M&E person, to basically address the issue of data quality. But as I said earlier, Professor Ndwati, the skill set of the HRO that was trained during our medical school, even before, is still the same. And we expect different results. Honestly, that's not possible. Therefore, we must upskill our HROs to basically give us assurance that the data that we are picking is reliable, accurate. But we have to begin somewhere, and I think we have begun. And with the collaboration with the partners and universities, I think we are on the right journey. But lastly, Professor Ndwati, what I said earlier on, as the counties owning their data, this is where the problem is. Because, as Lois said, when she's deciding a proposal, she will design a proposal to come and do research in Kakamega, but Kakamega has no idea for that proposal. Kakamega only comes in to pick the data, whose objectives are not known, whose problem statement is not known. So we need to begin from there and bring in the counties as owners of the data so that they can be co-PIs or PIs, whatever the matter. The capacity is there. Thank you, Prof. Ndwati, for taking so much work to explain us simple things.
Thank you, Dr. Wesonga. I don't know if Dr. Mburu is around or he's stepped out or he's here. Yeah, very quickly, Dr. Mburu, in the interest of time.
Yeah, thank you. I think that question Prof has asked is for all of us, and the answer is yes. These systems and the developers we have interacted with them very closely. The primary data capture tools are simply the ones that they have turned into electronic data capture tools. And therefore, the information that is captured at the service delivery point is the same. Of course, now the data quality issue comes because you have a new health worker interacting with a new approach. And the other issue is during downtimes. If, for example, the power outage happens or the system is down and they work off the system, are they able to upload that data after? And therefore, data quality issue is the next discussion. And we are all happy now that we are not discussing the rolling out the program, but now looking at data quality. And finally, what to do with that data. We now need now to go the scientific way, and we call upon the academia and other partners in this system now to onboard and come to us, because we have a lot of information that we have not been using hitherto. Thank you.
Thank you, Dr. I know this is a very charged conversation, but we'll continue the discussion after lunch. But let's all give a round of applause to all our presenters for a job well done. I know after the panel discussion, Dr. Elliot from EGPAF will lead us into really just acknowledging them. So we could break right now. I hope everybody has a meal card. Do we all have the meal cards? Okay, excellent. So let's break for lunch, and thank you for your attention.